Absolutely pleased to present one of my favorite topics as well, one in which I discussed almost every day, PGT-SR. Um, and I'm so pleased to be joined by Leoni, yourself, and Colleen as well, and excited to hear some updates from Colleen's research. So my aim and goal for today, I realize that we're getting a lot of the same questions from clinics and me personally from patients. So I thought it'd be helpful, as we did with the PGTM webinar, is to maybe do a deeper dive into it and look at an outline of some common themes that pop up that I can review and help understanding. So just as an overline, we will look at IVF together with PGTSR. I'm going to start with the clinical timeline and a couple questions and dispel those myths. I'm also going to just do a very brief review of both reciprocal translocations, Robertsonian translocations, and I feel that this is a deficit in, patient understanding or knowledge, particularly if they hadn't had an opportunity to meet with a genetic counselor clinically in the NHS prior to referral for laboratory genetic counseling. So we'll also kind of walk through the segregation diagrams, because that's common questions that I receive. Further on to that, kind of in the later 2/3 of the presentation, I'm going to review inherited chromosome microdeletions, microduplications. So when I say that, it's a referral to the resolution of NGS. So anything that's less than 5 megabases, we internally say that it is a microdeletion or duplication. That is included in pre-test enrollment counseling as well. Also, some frequently asked questions that we've received from our support team and patients is this concept of UPD. So I'm not going to review it in depth, but I've got some resources for further reading should you be interested. And I'll do a very brief outline of that, and we welcome any of your questions for discussion. And that leads on to that last point, as Tony say, I'll be joined by both Tony, Leoni, and Colleen, so we can have a very great interactive live question and answer session for any FAQs that we do receive in the chat box throughout this presentation. So looking at the kind of terminology, again, I know that you've probably seen this slide many times and it's been on both of my webinars, but I'm going to highlight the middle one. I'm not sure if you can see my cursor. This is the updated and new terminology. This has been adopted since about mid-2018. So it is a source of confusion for patients that I counsel when their ordering clinician, and the HFEA for that matter, still refer to the older terms as PGD for diagnosis and PGS for screening. So S, of course, is now PGTA for aneuploidy, and PGD previously referred for monogenic disorders and translocations, reciprocal Robertsonian, and sometimes more rarely inversions and insertions. So that's the focus today. Of course, that's now called PGTSR, hoping that we're all going to adopt this new term, and PGTM is the other updated term. So this is a common question that I do receive for patients and ordering clinicians. What is the quote unquote workup or optimization required for PGTSR? So I can elaborate this on in more detail in the frequently asked questions at the end of this presentation. But this is the clinical timeline that I reviewed in my previous webinar when we discussed PGTM in depth. And you can see I put a purple X across the test preparation, and in small parentheses here, you can see it's PGTM only. What this means is there isn't any required workup in terms of creating a bespoke test for testing any unbalanced form of translocations. And that's a nice take-home point today for everyone. This is what I counsel for patients. So what this means is actually it's good because there's no workup time, as opposed to what we have to do for PGTM and carrier mapping is create that bespoke test design, ask for DNA, and look for family member references. All of that is reviewed in the previous webinar. So just wanted to reiterate that we can accept your embryo biopsies from your fertility clinic at any time after you've finished your IVF treatment cycle. Ideally, we already had an inquiry, so we can do a case review. Our laboratory will do an analysis based on a G-banded karyotype and looking specifically at the breakpoints. They'll do it, then issue an inquiry report and then a genetic counselor review. And so I primarily counsel all of the SR referrals. This is sometimes a unique patient population in contrast with the other counseling that I do for PGTM. And then once, this would be the quote unquote workup required is the case review of the karyotype and genetic counseling for informed consent. And everything that's covered in an enrollment session, I reviewed in one of my first webinars last March, right when the pandemic was kind of starting. Gosh, that seems so long ago now. And then, so when couples, sometimes it's not uncommon for couples to have more than one cycle. So when you do start your IVF treatment cycle, and then your embryologist will carefully take a biopsy of the outer layer, the trophectoderm, and just a few cells. On average, it's about 5 or 8 that we receive in our laboratory here in London for testing and analysis reporting. And whilst that's happening, of course, the entire embryo that always remains at the fertility clinic is going to be frozen or vitrified until the genetic status of those embryos are identified in our laboratory. That takes approximately 2 weeks. That's a strict TAT or turnaround time that we impose on ourselves as a team. So moving on to reciprocal translocations. This diagram's on our website. That's where I've taken it from. And so all of our chromosomes come in pairs. So we've got a pair of one chromosome here, green. We can just randomly label that number 7. And another chromosome in light blue, let's call that chromosome 10. Could have easily been any of the chromosomes from 1 to 12, 13, 14, 15, 21 and 22 are involved in Robertsonian, so I'll review that in just a moment. So 7 and 10 is what we're going with here in this diagram. What's happened, so a break point at some point along this chromosome. So the short arm here is called the P arm, and the long arm here is called the Q arm. Not very inventive, just the next letter after the alphabet, P and Q. And what's happened here is that on one copy of this chromosome 7 on the long arm, Q, has broken off at this point and switched equally with the position on the long arm as well of chromosome 10. So what's happened here is we've got a balanced exchange, and you can see the end product here, and there's nothing gained, nothing lost. There's just simply a rearrangement of this chromosome. And because 7 and 10 are involved, this is a reciprocal translocation. Here's an example of a segregation pattern, as I alluded to in the outline. So at the top is the karyotype that is 46XX. That tells me it's a female that has this balanced translocation. This is happening, T, a translocation between chromosomes 9 and chromosomes 12. And this happens on the short arm, so P at position 241, and that's how you say it, not 24.1, 241. And that's referring to chromosome 9. And on chromosome 12, this is at breakpoint P, so again, the short arm at 131. PAT alludes to the inheritance pattern. This balanced reciprocal translocation was paternally inherited. So that's how you read this karyotype. This is what I would go over when I counseled clinically in the NHS to explain this karyotype result to a patient. So this would be the partners. I'm so sorry, it looks like the patient has got faded out here, but she has a balanced reciprocal translocation. And so when I counsel in clinic, I would use this diagram. I do include this diagram included with my counseling consultation letters. And so these are the gametes or the potentials of sex cells that happens. So her eggs, what could be the chromosome content of her eggs? It could be normal, so one that's not translocated. If we're using 9 and 12, for example, here, blue would be 9, 12 would be gray. There's that balanced reciprocal translocation, and then there's an unbalanced one where you've got too much of copy 9, and another one here where you've got too much of chromosome 12. So when this pairs up with her partner's sperm and her embryos are fertilized her eggs are fertilized to become embryos, hopefully, you can see that when his chromosomes match up and fertilize these eggs, we're going to have either normal balanced, so euploid 46 chromosomes, or we're going to have the same balanced reciprocal translocation. Moving on to Robertsonian. So I meant to add the chromosomes here, but just as I mentioned prior, this is for chromosomes 13, 14, 15, 21, and 22. These are called acrocentric chromosomes. You can see here, they've got very, very tiny P arms, almost non-existent. So these are acrocentric chromosomes. So sometimes what happens in a balanced Robertsonian translocation is that two acrocentric chromosomes, confuse together and create one derivative larger chromosome. That's a Robertsonian balanced translocation. So if we're using this example here, this tells me this karyotype here, 45, XY, this tells me this is a man that has the balanced Robertsonian translocation. DER is derivative between chromosomes 13 and 14. That's the most common Robertsonian translocation. And this is at position, at the beginning of the long arm, Q10, Q10, for each 13 and 14. And a common question I get from patients is, goodness, you're counseling that we want embryos with 46 chromosomes, but I only have 45. So, is there any impact on my health and medical management? All of that is covered in a clinical genetic counseling appointment. Hopefully, when a patient or a partner is diagnosed at the fertility clinic, that referral is still being made to the clinical genetic counselor in the NHS. That's really valuable for that couple to understand the karyotype report. I can elaborate that more on the Q&A session as well, the difference between clinical and laboratory. I can't do 2 one-hour counseling sessions, so I make some compromises. I do a brief summary in my letter. I will do a brief review during my session, but primarily what I'm focused on is laboratory techniques and specific to Cooper Genomics, explaining how we test embryos. So here, it's going to be very similar to what I just said. So I won't walk you through all the details here, but you can see there's actually 6 scenarios for this partner's sperm to have with this balanced Robertsonian translocation. And when one of these sperm fertilizes his partner's egg, this is what we're hoping for with our NGS results, either normal or balanced euploid. Both of these results are going to appear as 46 chromosomes on NGS. These are the typical unbalanced forms, either monosomy or trisomy. So one missing copy is a monosomy, an extra copy is a full trisomy. And again, the chromosomes involved are 13 and 14. Not going to spend much time on this diagram, but just wanted to include it just to kind of briefly review what a paracentric and pericentric inversion involves. So paracentric, you can see here, if we were to label the chromosome kind of sequence more simplistically as A, B, C, D, E, F, G, H, what happens here is that there is an inversion of 180 degrees so that it becomes A, B, C, F, E, D, G, H. And there's balance because nothing is gained and nothing is lost. We call this, because it does not include the centromere, a paracentric inversion. And conversely, a pericentric inversion includes the chromosomes. So you can see the sequence changed here. It includes the C above the centromere. It includes the D below the centromere. 180 inversion. Here we are. This slide you may recognize from my first webinar. So I wanted to highlight some of the counseling points that I do take into consideration and explain to couples prior to them usually prior to undergoing IVF, and explaining our genetic testing so they've got a good understanding and they can make an informed decision to proceed, having a chance to ask their questions and seek any clarification. So I do include that PGTSR does include the analysis for PGTA. So we're not only looking at the 2 chromosomes involved in the translocation. either reciprocal or Robertsonian. We're also looking at all of the other chromosomes concurrently with the same technology, NGS. So the technology has been updated. It's the PGT-AI platform, AI for artificial intelligence. Lots of my colleagues have given many talks on that. If you're interested, please visit our website. And more interestingly, we've got 2.0 and 2.0 plus. You may have some questions related to that. Let's keep that to the Q&A section. So the estimated overall likelihood that I counsel for either a euploid, no translocation at all, 46 chromosomes, or a balanced reciprocal translocation from our data that we've looked at, we've counseled and tested embryos from thousands of couples that have either the male partner or the female patient has a balanced reciprocal translocation, or maybe a person who's going through this process with a sperm donor or perhaps an egg donor. So what I say overall is that we see approximately 25%, so a quarter, of balanced, either balanced reciprocal reciprocal translocation, or those are healthy embryos that include no translocation at all. Our NGS technology cannot distinguish between the two, and that's one of the primary counseling things that I review, but also that's a common question I get from couples as well. Robertsonian's a wee bit higher. I counsel from our internal data set. Colleen, you probably have some updated numbers, so looking forward to hearing those. For Robertsonian, it's a wee bit higher. I'd say 30, sometimes up to even 38% within our internal data. Inversions and insertions potentially could be a wee bit higher. I counsel generally 40 to 50. We don't have a lot of data for that because they happen more rarely. Really what I want to emphasize here is the difference in providing these numbers as best estimates. These are what have been elucidated from a large analysis, from a large data set. It's really hard to translate these numbers when we only test 1 or 2 embryos, or if a couple's gone through multiple cycles, which is not uncommon for PGT-SR. We may not see definitively 1 in 4. And this concept of probability, this estimate is per embryo. So the likelihood of being euploid or balanced would be approximately 25%. The result from 1 embryo has no impact on the result of the next embryo. So just wanted to bring that point across. This is something I emphasize in common questions that I receive both in pre-test and in results counseling. But as you can imagine, more specifically in results counseling, when these numbers perhaps do not align. So counseling this and being upfront and giving that background helps ensure patient expectations are met or at least adjusted pre and post. So this was just a fancy slide. It's also on our website about our PGT-AI 2.0 platform. And this is the read data from our NGS at the bottom here. And you can see how these are aligned. I'm not going to spend a lot of time on that today. Mosaicism, obviously just a really quick review, is that unlike PGT-A or spontaneous aneuploidy, one that has no impact on either the patient or partner having a translocation. So we know that every single couple in the population, whether they conceive naturally or through the aid of the fertility clinic, has a chance of random aneuploidies happening. You've probably seen the graph in presentations from my colleagues. I chose not to use the graph today, but I just wanted to speak and make a point that maternal age impact for chances of sporadic aneuploidy, we are not seeing that with mosaicism. So I will briefly introduce the term, explain what it means. This would be an example of a euploid embryo, an aneuploid embryo, so any deviation from 46, more or less. Mosaic is when we see a mixture of the two. And the take-home point, especially when we're counseling results, is that we do not see that correlation between either maternal age, so the age of the egg, or paternal age, the age of the sperm, with mosaicism. We only see this in about 10 to 15% of our results in total. So I also counsel, once I've introduced that term, please be aware that this may not be a part of your result at all if your ordering clinician has requested mosaicism reporting. Moving on to microdells and duplications. So what happens when we use our next generation technology and we see a referral, perhaps it's an array CGH, and the copy number variation, the deletion or the duplication is pretty small. It's smaller than the resolution of our NGS technology, which of course is at minimum 5 megabases or higher. So what do we do if we see a referral? We've got an array report. Perhaps this is coming to light from an affected pregnancy. Something's been seen on the 20-week scan. The obstetrician wants to investigate further. Hopefully that couple's had prenatal genetic counseling for an informed consent, and there is an abnormal result back from that array. What to do next? Usually that's a quick and prompt referral to clinical genetics in the NHS. The genetic counselor or the consultant geneticist will be explaining that array result and be assessing whether or not it is directly related to what the abnormalities are being seen on the ultrasound scan. Whether or not we could rule out, no, it's not described in the medical literature as being related to what we're seeing in the presentation here in the current pregnancy. What has been described, and we can counsel that. So when we receive these reports, what I'm looking at to assess these, and I usually assess these because I'm the one counseling these if we do accept this for testing, is that this is a unique referral in that, yes, it is kind of a chromosome difference, but it's very small. And in order to test for this, because it's not within the resolution of NGS, we have to set up carrier mapping or linkage analysis. So I'm not going to review that. That's actually already been covered at great length in Demystifying PGTM webinar. I'll provide the link, I think, in the next couple slides if you'd like to review. So what I'm looking at is that my questions to the referring clinician is going to be, we do need to set up a positive reference to be able to test this via linkage analysis. So we need either stored DNA left over from testing during that pregnancy, particularly if that pregnancy did not advance further and perhaps was stopped because of the implications of the microdell or dupe. We could potentially have both of that report and stored DNA, and only if it's inherited from either the patient or the partner, or sperm donor or egg donor, however that pregnancy was conceived, we would also ask for that report. So we need 2 reports minimum, and we need DNA from either the patient or partner that carries that microdeletion or duplication. They may be completely fine and asymptomatic, have no phenotypes, have nothing seen behavioral-wise or visually related to that. So these are quite variable in the phenotype. And only if it's inherited, then we can set up linkage analysis or carrier mapping to actually investigate this and test in an embryo to see whether or not the embryo has inherited the chromosome with the microdeletion or duplication, or the other copy without. So it is indeed a 50-50 in terms of recurrence, same as autosomal dominant. I'm also looking quite closely at how the laboratory that tested for this microdeletion or duplication has classified this. Have we seen this in affected population, children with physical differences, behavioral issues, etc.? Is this a well-defined microduplication or deletion? I have some examples in the next slide. And if so, how has the laboratory classified that according to the ACMG guidelines, American College of Medical Genetics? And just to review again, 5 would be pathogenic, 4 would be likely path, 3 would be a VUS, so not enough evidence to support pathogenicity or rule it out. And then a 2 is likely benign and a 1 is benign, no supporting evidence for pathogenicity. This diagram kind of is actually a really nice diagram, courtesy of Greenwood Genetic Center, thank you. It kind of pulls together everything I just talked about, in that when I'm assessing these, here's kind of my thought process here. So at the bottom, if you can see my cursor here, what is the variant identified? What is this copy number variation? What is this very tiny deletion or missing information or extra information or duplication? We're going to look at the genomic data. What does the test report say? It's very, very likely that this couple has already been referred to clinical genetics for a complete assessment. I would really appreciate having a chance to look at those clinical notes from the referring clinician so that I can have an understanding of how that clinician has interpreted that information and thus explained it to the couple, including, we know recurrence risk will be 50-50 if one of the parents, this was an inherited microdel dupe. And this is a really nice slide kind of looking over what I was describing before and what we say phenotypic data. Further investigations could have been done in more individuals with the same copy number variation. So photos, is there a physical appearance that's characteristic? Medical imaging, vital signs, ECG, is it cardiac related or arrhythmias or cardiomyopathies, etc. So this one is just for some inherited microdells dupes kind of caveats or additional considerations, because my presentations, because I live and work in the United Kingdom, are always going to be focused on HFEA caveats and what we work with here, and as our laboratory here in London, servicing primarily most of the fertility clinics here in the United Kingdom, but worldwide as well, and adhering to those HFEA guidelines. So some of these microdells and dupes, as I alluded to on the previous slide, could actually be well characterized, well known, and maybe not that uncommon in the population. Some examples would be chromosome 22q11.2. I'm sure everyone's heard of this deletion syndrome. This is one of the more common ones that has cardiac implications. And depending on whether it is distal or if it's a deletion or duplication, there's different characteristics with the different sizes and where and how big or small these deletions or duplications are. And you can see there's multiple OMIM entries here. So if you're curious, please do log on to the OMIM website and read through kind of the phenotype associated with each of those. So another name for that deletion 22q11.2 is DeGeorge. Some other consultant geneticists have called it velocardial facial syndrome, or VCFS. Another common referral off the top of my head, and I listed on this slide here just to prompt me, is 16p112. Likewise, I feel that 15q112 or 15p112 is also one of those common ones that does indeed have an OMIM entry. So hopefully that's, I don't know if that was too rushed, but I was trying to give an overview. And if you have any further questions, please don't hesitate to submit those in the chat box and we can address those in the live Q&A together. And then this slide I added because I just want to walk you through as well. This would be an example chromosome 22. So this is a maternally inherited chromosome 22. Deletion 22q131, and the size you can see is very tiny. It's about 387 kilobases, so not even a half a megabase here. I know that doesn't really mean much to people outside of genetics, but again, this is a chromosome that's kind of laid on its side here from what we're usually seeing in diagrams. But this is the centromere here. It's labeled P111, and then down to the end of the chromosome, the telomere. So this, if we're going to enhance this region here, and we see here on this cytoband at Q131, and then the pink box here is more specifically within that region. There are actually 18 genes in that small, tiny region and 10 different OMIM entries. So these referrals can be quite complex, and this is sometimes why we then ask further questions to the referring clinician. If you're not sure how to answer those questions, we would love for you to be in contact with the referring clinical geneticist or the referring clinical consultant geneticist to shed some more light on how was this couple counseled, what are these 10 OMIM gene entries, what are the 18 genes associated, do we know the function of these genes, how can a deletion or duplication in this region impact all or some of these genes and potentially have a clinical phenotype for this pregnancy or perhaps newborn. Maybe this was found investigation after behavioral issues. We don't know. So that slide is just kind to highlight it can be a lot more complicated than just a copy number variation. This is the link that I promised you earlier in the review of the PGTM webinar that Tony and Leoni and I did together. And we answered some of your frequently asked questions. So if you have more questions related to carrier mapping and linkage analysis and how we use that for assessing microdells and dupes for testing embryos, I would encourage you to go to our website and have a nice little review of that webinar. The link is provided here. So actually, if you just Google Cooper Surgical and the webinar library, you'll find that quite easily. Lastly, just to kind of wrap up before our Q&A session, I've got a few minutes left. I am looking at timing here. UPD, uniparental disomy. Goodness, we're getting a lot of questions about this recently. What I would love to reassure everyone here is that a majority of chromosomes, for a majority of chromosomes, uniparental disomy is without clinical consequence. However, for chromosomes 6, 7, 11, 14, and 15, or 20, there are parent of origin, or what we call imprinting differences, so differences in gene expression, depending on the parent of origin in the context of UPD. This can lead to phenotypic abnormalities. So if you have more questions and you really would like to learn more about UPD and this phenomenon, I would really encourage you. I have a screenshot of the latest paper that I circulated to colleagues as well, diagnostic testing for UPD and points to consider. And this is an ACMG statement, so American College of Medical Genetics. Really great paper. This paper had influenced my counseling and our letters as well and recommendations. So I won't review the paper in detail. I'll leave you to investigate that and have a read through if you'd like to learn more about it. But one of the things that it did advise us as genetic counselors and Cooper Genomics in general, when we are counseling for mosaic results, mosaic embryos with either a trisomy or monosomy of any of those chromosomes mentioned before, 6, 7, 8, 14, 15, and 20, the recommendation from ACMG is that if a couple choose to implant a mosaic embryo with one of these, mosaic for one of these chromosomes, we always counsel that prenatal testing should follow should an ongoing pregnancy be achieved following the implant of an embryo based on our genetic testing results very, very early in the developing embryo, the day 6 trophectoderm stage, blastocyst stage rather. But the guideline says that both prenatal and UPD testing should be done via amniocentesis. And this is what our genetic counselors counsel as well, because a mosaic embryo, rather than a CVS, we are encouraging a diagnostic prenatal testing via amniocentesis. If you have any further questions related to that, we can answer that. Please do submit those in the chat box. And I've referenced that paper if you wanted to have any more insights and diagrams. I just couldn't take a lot of time during this short webinar today to kind of go over the mechanisms or the clinical consequences. I found it personally a very interesting read. This is something that we've done in our training as genetic counselors, and I could speak about at length, but I'm going to not do that today. But really encourage you to seek out that paper and learn more about it. So at Cooper Genomics, generally speaking, what we counsel and what we say is that we would consider UPD testing for a Robertsonian translocation involving chromosomes 14 or involving chromosome 15. And if you have any other supporting evidence from either a consultant clinical geneticist in support of UPD testing, we would be happy to review that. But generally speaking, that's what we advise clinics. So when I do counsel couples where there's a Robertsonian translocation involving chromosome 14 or chromosome 15, I will always be counseling about the chance of UPD. It is very, very rare. I really want to emphasize that today. In the medical literature, it says it's approximately less than 0.05, so less than 0.5% of a live birth baby with UPD with UPD, either 14 or 15. So that's what's published in the medical literature, and this is what I counsel. Couples are really reassured by this, and they know that testing can be done if they're already planning to do prenatal testing, diagnostic testing, should a pregnancy be achieved after their IVF and PGT-SR cycle. One quick note, I did mention this in my first webinar. It is a stipulation of accepting NHS funding, is that couples are not permitted to quote unquote top up and pay extra for any UPD testing, even if it's, you know, recommended or warranted. This can be tested through prenatal testing. So the NHS sees this as an add-on test, so that's not permitted. So any couples that are coming through the UK for testing from UK clinics, UPD testing is not an option. Lastly, I just want to conclude here just by referencing the ESHRA guidelines. I don't want to be biased for American publications. Obviously, what's pertinent to us in the UK and in the EU is looking at our governing body as well, ESHRA. And the consortium here has updated their just recently in 2020. So I had done a presentation on specifically the recommendations for PGT-SR. Just want to reference this paper here for your further reading. And thank you very much. I really appreciate your time. And back to you, Tony.
Thanks very much, Jen. Really interesting webinar there. Great sort of introduction to the PGT-SR field. So we do have some time for some questions, and we've had some questions come through. So what we'll do is we'll crack straight on with the questions and see how far we'll get through. So the first question goes to Colleen. Jen mentioned UPD in her presentation. Maybe you can tell us what's the actual technical reason why we don't test for UPD as opposed to the kind of clinical thoughts that Jen mentioned?
Yeah, thanks, Tony. So the short answer to that is, as Leoni would tell you, that the tests that we use in the genomics laboratory have not been validated for uniparental disomy. Which obviously doesn't mean that the test isn't technically capable of detecting it. It's just that we've not been able to do the extensive validation that is required for accreditation. Now, the reason for that is, as Jen mentioned, the very low percentage of embryos that we would expect to see it in. And obviously, as you mentioned at the beginning, I've been studying a lot of our PGT-SR data as part of my PhD. And in fact, in all of the cases where we have tested for uniparental disomy, or where we have performed parent of origin testing, we haven't actually identified uniparental disomy in the samples that we've tested, which obviously then excludes us from being able to do a validation. And just to back up the numbers that Jen gave, there was a publication in 2014 where they looked at 3,401 embryos, and they identified UPD in 2 of those embryos. You know, so again, you know, that one is a reason why it's technically not been possible for us to validate it on our technology. But secondly, it's also a reason, obviously, a reassurance that we can give to patients, you know, that it is low risk.
Thanks, Colleen. Yeah, it's an odd catch-22 that you can't validate it because you don't see them, so you can't see them because you don't validate it. Yeah, it's an interesting one. So we'll move straight on, and it's a question for Leoni. When we get the information about a case coming through, generally it's that wonderful mysterious language of karyotypes that I so love, but also we occasionally get information from a microarray from a termination of pregnancy or product conception. Maybe you can explain, which one is more useful and how we go through the process of analysing whether a case is suitable from that karyotype or microarray result.
Yeah. So we review each referral on a case-by-case basis, so we see what documentation is available. We generally prefer to have a standard G-banding karyotype report. Sometimes we might get a FISH report, or as you said, an array CGH report. We review everything we get, and we sometimes might request additional documentation because we want to be sure that the breakpoints that are stated have been mapped accurately. Well, the position of the exact breakpoint is mapped accurately to the closest band, because that will determine our ability to accept the case, because it determines how big the translocated segments are. Having said that, yes, we would prefer to have a G-banded karyotype. An array CGH report can also be useful. FISH reports are what we usually are not as happy to accept without supplementary information. There are sometimes cases that, based on the breakpoint location that we have, fall below our limit of detection based on the initial review of the referral. So for those cases, we might ask for additional information, such as perhaps an unbalanced DNA sample. So if there is a report on a termination of pregnancy or CVS, we might ask for an aliquot of that DNA to test on our platform and see if we can detect the imbalances, confirm that we can detect them.
Thanks, Leoni. Yeah, it's always useful to have that extra information, because sometimes karyotypes can be wonderfully imprecise and written in such a way as to kind of not give us enough clues. And clearly we want to do the best for the patients in these cases. So yeah, it's interesting the different sort of levels of information, we get, and you think it's just going to be SR karyotype, but there's all sorts of information. So we've got another question here, and it kind of goes back, and maybe we can just reiterate, and it comes from the audience, and it says, talking about balanced translocations, they're not rare, as Jen clearly pointed out. Around 50% of embryos are balanced for reciprocals and Robertsonians. So how can it be then that you only have 20 to 30% chance of embryos that are either euploid or balanced, suitable for transfer? So Jen and Colleen, maybe you can comment on this.
Sure. I'll just give the obvious answer, and maybe Colleen, you have more insight. But from a counseling perspective, recall in my slides that when we do receive referrals for PGT-SR, and I am doing the enrollment and pre-test counseling, keep in mind that we are including analysis for PGTA analysis. So we will see a maternal age impact. So in addition to any unbalanced form of either the balanced reciprocal or Robertsonian translocation that either the female patient or the male partner has, we are also identifying aneuploidies, spontaneous aneuploidies, nothing to do with that translocation, as a consequence of the age of the egg, which of course is the age of the mum at the time the egg was collected and fertilized to become an embryo. So in that overall number that I do counsel is based on Cooper Genomics internal data, based on testing thousands of embryos from and we looked at the cohort for only reciprocal versus only Robertsonian cohort separately, and that's where we got those different numbers. And that number that I counsel is an estimate. It's based on an overall trend that we saw. What is the number of euploids that we saw when we tested these embryos? But keep in mind that's unbalanced and that's spontaneous aneuploidy based on maternal age correlation. So Colleen, I'm not sure if you have anything further, I think, on your analysis. Did you see that those numbers were kind of held true, or what are your thoughts?
Yeah, I mean, basically those numbers do sort of hold true when we look at sort of the last 5 years of NGS data. And just to highlight what you said, Jen, about the difference between just the unbalanced embryos and what we actually want to use for treatment. So if we look at our patients with reciprocal translocations, it was just about 57% of those that were unbalanced. But if we actually look at the PGTA data included in that, we're down to 22% of embryos that we want to actually use in the patient treatment that are both euploid for the chromosomes involved in the translocation and euploid for the other chromosomes as well. So it does really highlight that, you know, these patients are, you know, at the same risk, same population risk as any other patient, you know, of having aneuploidy that's unrelated to the translocation as well.
Thanks, Colleen. I just thought of something I would like to add as well, because maybe it's just not obvious or intuitive for a lot that don't talk about translocations every day like I do. But some questions I received from couples is that, you know, in addition to what Colleen and I said already, you know, the unbalanced form and the spontaneous aneuploidy, these are not mutually exclusive. So the embryos can have either, you know, an unbalanced form of the translocation in addition to an aneuploidy spontaneously. I've seen those in results. I've counted those results. Likewise, I've seen results that are multiple unbalanced form of the translocations, the chromosomes involved in that translocation. And then I've seen separate embryos that have a spontaneous aneuploidy, for example, trisomy 21, more commonly known as Down syndrome. So again, we can't predict the biology. We will only know when we actually test the DNA from the embryos. So again, reiterating, large data set, overall number may not necessarily translate to receiving and testing 1 or 2 embryos or 4. There's no guarantee 1 in 4.
And sorry, Jen, just for me to add to what you just said as well is, of course, the percentage of embryos that we have suitable for transfer, again, is different to what is the patient's chance of actually reaching embryo transfer. And when we've compiled our sort of last 5 years of data, although we've said, you know, the chance of a patient with a reciprocal translocation, about, you know, 20 to 25% of their embryos will be euploid or balanced, we actually see 55% of cycles getting to embryo transfer. You know, so again, that's a separate measure, because as you've said, you know, the results from each embryo don't necessarily relate to each other. So as I say, yeah, that's a separate measure to look at.
Thanks very much. Really, really interesting information there, I think, and hopefully that clears up that question. So I have a question for Leoni. Clearly, we like to take on any cases that we can for PGT-SR, but there are some cases we can't. And the question is, you know, what can we not accept? I think this refers to translocations involving chromosome Y, ring chromosomes, and marker chromosomes. And maybe you can explain, first of all, for those people who are not in the cytogenetics world, what a ring and a marker chromosome is, and, you know, why we can't accept those classes of cases.
Yeah, I mean, yes, you're right. We would like to be able to offer testing for any type of structural rearrangement, but, you know, we also have to be mindful of what the risk is of an unbalanced form going undetected using the technology we have right now. So yes, I think you summarized it correctly. So cases with structural rearrangements that involve the Y chromosome, ring chromosomes, marker chromosomes are cases we usually do not accept. The reason for that is the size of those abnormalities is very, very small. So we usually won't be able to detect the presence of a derivative chromosome. So we don't accept those for testing. Other cases we might not accept are cases that, as we discussed below, it might be a normal standard reciprocal translocation, but if the breakpoints are very close to the telomeres for both chromosomes, our probability of detection for that specific translocation might fall below our acceptance criteria. So for such cases, we will try to do extra investigations based on what DNA samples might be available for us to test in order to provide a test for that couple. But there are rarely, but sometimes there are cases that we cannot proceed with a PGT-SR test.
Thanks, Leoni. Yeah, it's always disappointing when we have to turn one down, but at the same time, we don't want to take on cases where it's outside our ability to test. So very, very interesting. Great question for Jen, actually, this one that's been put through. And it's something I think a lot of people don't understand. Maybe you could explain, Jen, what the difference is between what an NHS clinical genetics counsellor is and yourself as an IVF laboratory genetic counsellor. And I guess this comes back to, well, I've been to the NHS genetic counsellor. Why do I have to talk to the laboratory genetic counsellor?
That's a really great question. Thanks for, I don't know if that came through the chat box, but thanks for asking that.
Yeah, it did come through the chat box.
Yeah, I alluded to this in my presentation, so maybe that's what prompted the question. It actually is one I hear quite frequently. So you're not alone, whoever sent that question in. And couples that I counsel, I explained at the beginning that I'm hoping that you've had a chance to speak with a clinical genetic counselor in the NHS. So most of our PGTM referrals, that's almost a guarantee, because that's the person who is facilitating the testing, either predictive genetic testing or diagnostic genetic testing, if that person has signs and symptoms of a disorder and it's part of their diagnosis. Or clinical confirmation of their clinical diagnosis, let's say. So predictive is when they have a family history, perhaps it's a later onset. So in the NHS, where I worked for years, but also in Canada in the public healthcare system, the traditional role of a clinical GC is within a team of clinical genetics department rather. And that's usually a team of many genetic counselors, admin staff as well as sometimes genetic counselor assistants and consultant clinical geneticists. They're probably less in numbers than the team of genetic counselors. So I worked with a very big team, Southwest and in England here, but also in London and up in Manchester where I did my training. So these are the conversations we have. We'll take the full family medical history. We'll describe what the disorder is like, the natural history of it, the inheritance pattern, explain autosomal dominant, recessive, X-linked recessive dominant, etc. Any preventative screening or prophylactic surgery that could, like, I'm just thinking of BRCA1, 2. I counseled exclusively BRCA1 and 2 testing in Toronto and Mount Sinai. So, these are all part of the clinical care. That genetic counselor is that patient's clinician. They're the one making the further referrals, recommendations from the GP, writing the letter, maybe even writing standard template letters to family members that are at risk, implications not only to that individual, but their family members. So their first degree relatives, their siblings, their parents, their children, wider family as well. And so that's kind of an overview of the traditional clinical genetic counseling. And if I were to apply that with why I say that it's important and why most karyotypes will say genetic counseling recommended, is that we want that couple or that individual to go to clinical genetics to have that time, that protected time. What is a translocation? How did this come about? Is this inherited? Is it sporadic? Is it something I can pass on? Is there any implications to my own medical health and management? All of that is covered, even basically, what is a chromosome? All covered in clinical genetics. So if that individual or couple is not referred to clinical genetics before they see me as a laboratory genetic counselor, it makes what I have to say not really, it's really hard to understand if I'm then going into the technical aspect related to the laboratory and how we apply next generation sequencing, the risks, the benefits, the limitations, possible outcomes, turnaround times, accuracy, recommendation for prenatal testing. All of that is covered in my 45-minute, 60-minute, depending on if the couple have lots of questions. So it's really laboratory based, kind of a brief overview of IVF and detailing how our laboratory fits into their IVF PGT-SR treatment cycle. So I'm hoping that is, a good explanation of the difference. And sadly, I don't counsel a lot of SR couples that have had clinical genetic counseling. So sometimes I can do a hybrid and supplement with resources for further learning.
Thanks, Jen. It's it's always one that I think people find difficult to differentiate. So we're kind of coming towards the end of the hour, but we have time for a couple of quick questions. One, actually, we did wonder whether this would come up, and it's one for Colleen, and it says, ICSI is recommended for PGT-SR and M, but not necessarily for A. Is it due to the fact that SR and M look at smaller chromosomal regions and hence less chance of contamination? Or sorry, rather larger chance of contamination because you wouldn't see it. Colleen, maybe you'd like to talk about this. I know it's a subject close to your heart, this one as well.
So yes, so the reason historically why ICSI was recommended for any sort of amplification-based pre-implantation genetic testing was because of the theoretical risk of a sperm being tubed along with the embryo sample and then going on to contaminate the results. What we know now is obviously we've got a couple of different tests that we do, PGTM, PGTA, PGTSR. PGTM uses one specific technology and PGTA and PGTSR use a different specific technology. So there is sort of published data available already, which does show that sperm doesn't amplify, or sperm needs modified amplification methods compared to what we use in the laboratory if we're using the same methodology that would be used in PGTA or PGTSR. And we've done additional work on that and have a paper which should be coming out in Human Fertility soon. So really what I would say is that with PGTM, if you get a sperm in the tube, it will amplify, it will contaminate your results. In terms of the laboratory, with Leoni using carrier mapping, they should be able to detect that, but obviously it's not ideal. With PGTA and PGTSR, your sperm shouldn't amplify and it shouldn't impact on the results. However, we're still in the situation where a lot of the guidelines and recommendations still actually do state that ICSI should be used. So because of this, some people still err on the side of caution and prefer to use ICSI in terms rather than IVF. Some people, I think, are more switching to IVF for PGTA, but obviously with PGTSR, as Jen has obviously shown quite nicely, you know, we're at a risk here of a specific inherited disorder. You know, so I think people are more on the side of erring towards caution, especially based on professional recommendations and guidelines. But if we look at the sort of scientific literature, there's not masses of support in terms of reasons why we would need to use ICSI.
Thanks, Colleen. It's an interesting one where, as ever, the science is kind of slightly ahead of the guidelines, which is, you know, so often the way. So we have promised last question, and it kind of is a hybrid question for Leoni and Colleen, and it's to do with kind of incidence of reciprocal and Robertsonians. I think reciprocal translocations are thought to be about 1 in 500 of the population, Robertsonians 1 in 1,000, but you know the data is very woolly on that. You know, nobody's karyotyped the whole population, so we don't really know. But do we see translocations with both parents? Is to Colleen, and maybe Leoni, you could mention very briefly what a cryptic translocation is and how that impacts PGTA. Colleen.
So in terms of finding translocations in both parents, it is possible, but it's rare. And I would say in the time that I was operating within the lab doing PGT-SR, I came across 3 cases. One of them being a case where they were referred through with both of them having the translocation, and the other 2 being ones where we actually identified an additional translocation during the testing. So we thought we were dealing with 1 translocation, but there was actually 2. And that obviously, again, highlights the information that Leoni was giving about why it's so important for us to know the breakpoints of translocations and exactly what we're looking for, because when we see something that's not what we're looking for, we're like, oh, you know, what's happening here? Normally, you're at a more increased risk of that if you're dealing with a consanguineous couple or a couple from a particular ethnic group. But interestingly, the 3 cases that I've dealt with, you know, we're not at that risk. So it was just very, very bad luck on their part. So it can happen, but it's pretty uncommon.
Leoni.
Yeah, I agree with Colleen. Just to add, we also had cases referred to us where one partner had a translocation and the other partner had a single gene disorder, for example. So we have seen different combinations. Your question before about cryptic translocations. So sometimes we have PGTA referrals that we test on NGS. And when we look at the results, especially if there is, you know, more than 3 embryos, so you have kind of a larger number of embryos, so rarely, but we have seen that in quite a few cases. We see in the different embryos tested deletions or duplications with the same breakpoint on the same chromosome. So that is really indicative that there is a background reason that this is happening. So we would make a note on our report that the findings are suggestive of a structural rearrangement in the patient or the partner, and we recommend follow-up testing to see if one of them is a carrier.
Okay, thanks, Leoni. Very clear. Jen, last comment.
Yeah, what Colleen was saying just made me think of something else. And in terms of population risk, Tony, I think it really depends on what publication you're looking at, of course, and where in the world. So I would generally say a range just to be on the safe side. Maybe even 1 in 100 to 1 in 1,200 is usually what I counsel. I don't know if that's specific to Reciprocal or Robertsonian, but as you say, I mean, the caveat there is that we don't karyotype everyone in the population, so we don't truly know. That's the catch-22 of it, right? I think it's much more common because I talk to couples every single day with either one of them. And lastly, I just wanted to comment about just general practice in the fertility clinic. When I'm taking family medical history, what I'm looking for generally in these family histories are unexplained infertility, which is likely why the couple has, you know, self-referred or you know, sought the help of a fertility clinic. Or sadly, these couples have been through 1, 2, 3 or more, multiple miscarriages. So kind of generally what we used to say in the clinical genetic counseling in the NHS is we're taking a family history, 3 or more spontaneous losses or pregnancy with the same partner, of course. You could, you know, take into account previous partners that you could see a pattern there. But generally, please go ahead and order a karyotype because you could identify a balanced Robertsonian or a balanced reciprocal translocation without subjecting that couple to perhaps even years or months more of not knowing why they're not having success either naturally or through you know, IVF without genetic testing. So that's kind of my take-home message today.
Yeah.
Well, I'm sorry, I know that was meant to be the last comment, but actually, just in terms of what was said of incidents, you know, population incidents in terms of the general population is different from population incidents within a fertility clinic, you know.
Absolutely.
And if you've got somebody that's referred to a fertility clinic with unexplained infertility, there's a higher chance of finding
much higher incidence.
The more miscarriages somebody has, the higher an chance they have of finding it, you know. So we need to be aware that we're already dealing with a population who have a higher risk of actually having a translocation present.
Well, I would just like to sort of say thank you very much. As ever, the time in these things goes far too fast. And I'm sure with this particular group, we could have been talking all day, and we probably will continue talking all day because it's a fascinating subject. It's a fascinating subject. So I'd like to thank all the attendees. I'd like to thank them for their questions. I'd like to remind you that we have ongoing webinar series. You can go to Cooper Genomics and look at those webinars. There's a particularly interesting one coming up on the 9th of June just in a couple of weeks' time, where we are looking through some of Colleen's data that she's been collating, looking at no results. You know, a really crucial subject for patients. So no results in PGTA and what you can do to deal with them and the data there. So we're really looking for that webinar. And really just to thank the webinar givers here, Colleen, Leoni, and especially Jen. Thank you. Excellent webinar, and thank you for all the attendees for joining. Goodbye.